Right. Good morning, everyone. Welcome to Pediatric Grand Rounds. Today it's our pleasure to have Dr. Mebratu Daba, Department of Pediatric Neurology, as our speaker. Dr. Daba trained at Brooklyn Hospital to complete his residency in pediatrics and completed his fellowship in child neurology at University of Florida. Dr. Daba came to us from Addis Ababa University, where he had already trained in pediatrics with extensive experience in practice as well. He is currently board certified in pediatrics, psychiatry, and neurology with special qualifications in child neurology. He joined the CARILION Clinic in 2018, where he has quickly distinguished himself for his clinical skills and his love of teaching. Please join me in welcoming Dr. Mebratu Daba.
Thank you, Dr. Parmeshwar. So the topic of my today's talk is, as you can see it on the screen, it's a sleep-wake cycle and related problems in adolescents. Just to give you a little bit of background why I chose this topic is the large bulk of our pediatric service is about epilepsy. I thought this is a little bit different from what we usually encounter in ED or on the pediatric services. It is based on a case which I was consulted on 4 months ago from the pediatric floor. That's in July. I thought that will be an interesting case. The main objectives of my talk are introduction to pediatric sleep disorders, how to screen sleep problems in children, with particular emphasis on excessive daytime sleepiness in adolescents and the potential causes for this problem, and also to give a little bit of an overview of acquired and autoimmune demyelinating disorders which can manifest with excessive daytime sleepiness. And I have no disclosures. Some basic definitions of sleep-related disorders in children and as well in adults. Dysomnias are disorders of initiating and maintaining sleep. Hypersomnias are excessive sleepiness. And most pediatricians see kids with parasomnia, abnormal behavior or activity during sleep, like it could be sleepwalking, sleep talking, paroxysms, and other related problems. These are very common, and parents sometimes get referred to our office to rule out the possibility of seizures in sleep. So probably most residents and also most pediatricians use this mnemonic to screen sleep disorders. It is done as an anticipatory guide starting from infancy to adolescence, and it's BEARS, BEARS. B is for bedtime problems like difficulty going to bed or difficulty falling asleep. The E is for excessive daytime sleepiness. A is frequent awakening in sleep. And R is for regularity and duration. How many hours do they sleep? And is it regular or they wake up frequently? S is for snoring. So the amount of sleep progressively decreases from the newborn age to adulthood, and newborns sleep up until 18 hours, and adults the average is 7 to 10 hours. So adolescents are close to adults, around 8 to 10 hours. You see the red zone is if it is more than 10 or 11 hours for newborns, more than 19 hours, that is excessive, and anything below 5 for adults is not adequate, and for adolescents less than 6 or even less than 7 is not adequate. So the one that you see in the green zone is the one which is considered to be appropriate. So coming back to my case, which I was consulted in July, she is a 14-year-old, previously healthy female. She is African American and admitted to the pediatric floor due to excessive daytime sleepiness, which she has been experiencing for about 4 weeks before admission to the hospital. And she sleeps for about 30 minutes up to 2 hours, and she will be awake for about 1 or 2 hours, and that is on and off, on and off. And there is no other sleep problems prior to this. She had regular bedtime, sleeping going to bed around 11 p.m. to midnight, up to she wake up at 7 a.m. in the morning for school. That was her usual routine. During the daytime, she is always alert, awake, and attentive. This was completely a new problem for the patient. No history of snoring, no history suggestive for cataplexy. Besides the sleep problem, she has issues including forgetfulness and mild difficulty swallowing with coughing briefly after swallowing. These are the other additional informations that the patient had. And actually, she went to her primary care doctor, to a pediatrician, and the pediatrician requested MRI of the brain, and the brain MRI showed abnormalities, which prompted him to refer the patient to our hospital. So this is actually one of the learning points here, which I would like to mention. Probably you see, especially many pediatricians see adolescents who are sleepy during the daytime, unless really parents bring it up to the pediatrician's attention that the patient's sleep is completely fine. This is totally different. Usually we blame it on teenage behaviors. It is unusual, to order MRI for patients who are coming with these symptoms right from the beginning. So I think the pediatrician did a good job in taking a good history in terms of taking the words of the parent and proceeding to further look for potential other problems. So the patient's exam was completely unremarkable, except that she was not even able to finish sentences during the history-taking process. She just dozes off, drifts off and on, drifts off and on. She sleeps for about 15-20 minutes, and she wakes up in the middle of the history. So narrowing my talk to excessive daytime sleepiness, as the term describes itself, it is a subjective feeling of irresistible daytime sleepiness in unusual time and at unusual locations. And it affects about 5% of pre-adolescents and up to 20% of pre-adolescents, up to 5%, and adolescents 20%. The exact cause is not known. It can be so many different things can be a cause for excessive daytime sleepiness, which I'm gonna talk about those. So the causes can include, obviously, if the patient doesn't have sufficient sleep during nighttime, they will be sleepy during the daytime. Not only the amount of sleep, if the quality of sleep during nighttime is not good, there is obviously a problem during the daytime. So fragmented or poor quality sleep is another contributing factor. Once we rule out this, where the amount and quality of sleep by the screening mnemonics that I mentioned, then we have to think of increased drive for sleep. That means the central hypersomnia. So these are the causes for central hypersomnia: narcolepsy, idiopathic hypersomnia, Klein-Levin syndrome. Some medical conditions can cause excessive daytime sleepiness. or CNS pathologies, which I'm going to talk about in relation to the patient, and some medications like benzodiazepines and other medications that you use, especially for seizures and other things. So the central causes, I'm going to focus on the central causes. This include anything that can affect the brain, particularly parts of the brain which are involved in sleep-wake cycle. So it can be those structures can be affected due to trauma, malignancy, infections, autoimmune disorders, or vascular abnormalities, or degenerative disorders. This is a kind of the sagittal section of the brain, just to give you an overview of which part of the brain is involved with the sleep-wake cycle and what kind of neurochemical transmitters are also contributing for that. So this is here is the frontal lobe here, and around here is the diencephalon, where the thalamus here in purple in the middle, and the hypothalamus just below it, and around here in the back you see the brainstem, pons, and medulla, which is extending down to the spinal cord. So there are ascending tracts and neurochemicals which keep patients awake, and there are opposing descending chemicals, neurochemicals, which cause sleep. So the sleep-wake cycle is actually a balance between these competing neurochemical agents, and the sleepiness or wakefulness depends on, a balance between this, whichever side it tips. And here you see the light, the sun source, and also which is directly affects the SCN, that is suprachiasmatic nucleus, and that suprachiasmatic nucleus will trigger the ventrolateral preoptic area, which is predominantly GABA, and that area is the GABA is, like, as you know, it is an inhibitory neurotransmitter, and it inhibits most of the biochemical agents which cause wakefulness. So the neurochemical transmitters which keep us awake include, histamine, glutamate, acetylcholine, neuroadrenergic agents, and dopamine. And the GABA opposes all this. So if the histamine, glutamate, acetylcholine, noradrenergic, all these things are on the higher side, then we'll be awake. If the GABA is on the higher side, we'll be sleepy. So it is a balance between these things. What keeps these things on and off? There are two factors. One is light. Here on the picture, you see the picture of the sun. The other thing is temperature. So when our body temperature goes down, the GABA will be on the higher side. That's why we tend to fall asleep around 10 p.m. or 11 p.m. That's when most people feel asleep as environmental temperature goes down. In the morning around 6 and 7, the environmental temperature again starts to rise up, and the GABA goes down. The other thing is, like as I said, the light, which affects the suprachiasmatic nucleus. So when we get a patient with excessive daytime sleepiness, like in any clinical disorder, take history, we do examination, and for the excessive daytime sleepiness, we do subjective assessment of sleepiness, which is Epworth's sleepiness scale, which is particularly which is modified for children and adolescents. It's called CHAD, children and adolescents. And the objective tests include polysomnography, which is a multiple sleep latency test. CSF hypocretin level is not currently a practice in the United States. It is used in Europe, We don't do it here unless it is for research purposes, and MRI is another assessment tool. So here is the MRI of our patient. Here on the first picture, you see the sagittal T1 view, which is actually completely normal. That is no abnormalities. On the T2 flare on this side, you see this hyperintense spot. So that is in the subcortical white matter area, which is a manifestation of demyelination. And as you scroll this images further, you see more demyelinating lesions around the periventricular region. You can see it here as well. And this one is a sagittal section, a little bit, it looks like a little bit blurred, but you see this on the first image, the hyperintensity on the periventricular region, which looks like projecting from the corpus callosum. And that hyperintensity also involves here on this other image, the thalamus and a part of the hypothalamus. So just to summarize the case, 14-year-old previously healthy female admitted due to excessive daytime sleepiness, and imaging is significant for multifocal demyelinating lesions. And this is the first time demyelinating attack for this patient and presenting with excessive daytime sleepiness. So can we consider like this excessive daytime sleepiness as encephalopathy? That's one question, because it is an important point to make to narrow down our differentials. If we consider the excessive daytime sleepiness as encephalopathy with first-time demyelinating attack, our differential will be very specific. The diagnosis will be very narrow. So let me give you like a little bit of information about the acquired demyelinating syndromes. Acquired demyelinating syndromes are disorders which are monofocal or multifocal lesions originating in the CNS and caused by inflammatory demyelinations. These demyelinating disorders can be due to infection, multiple sclerosis, neuromyelitis optica, NMO, or it could be due to vasculitis or other leukodystrophies. Leukodystrophies are usually kind of congenital, but they can manifest late in some conditions. Endocrine conditions can cause demyelination. One which is commonly known is steroid responsive encephalopathy due to autoimmune thyroiditis. Vitamin deficiencies like B12, vitamin E, folate deficiencies can cause this. And lupus and infections, like as I mentioned, mitochondrial disorders also can cause demyelination. So we can narrow down the differential in this patient, like infections are less likely because the patient has no fever, no evidences for infection. CBC was normal. We did infectious workups as well. Those things where all viral infections are negative. Most viral infections are negative, except that she was positive for Epstein-Barr virus IgG. One is IgG. Here I put for both of them IgG both times, but she was non-reactive for IgM. She was reactive for IgG. Other than that, there was no evidence for infection. We did some autoimmune workups, including ANA, double-stranded DNA, which were negative. This rule out like Sjogren and lupus. Aquaporin 4 antibody is negative. I'm going to come back and discuss about that, why that is important. And anti-MOG antibody is also negative in this patient. So vitamin deficiencies are out. Infections are out. She has no risk factors for vascular disorders like no diabetes or hypertension. So our question is, what other demyelinating conditions can be contributing for this? Here is a classification for acquired demyelinating conditions. they can be monophasic, that means one time, or they can be recurrent disorders. Because this is the first episode, we basically will not consider the recurrent episodes at this time unless we have additional informations. So what monophasic conditions can be considered as differentials? So one is clinically isolated syndrome. This basically means that a first demyelinating disorder with no encephalopathy but does not fit a criteria for multiple sclerosis. That's defined as clinically isolated syndrome. It is some features of MS, but doesn't fulfill a criteria for MS, and patient is not encephalopathic. Then we classify that patient as clinically isolated syndrome with a patient with CIS. If it is a first-time attack with evidence of demyelination, not meeting criteria for MS, but the patient is encephalopathic, then that is a criteria for acute demyelinating encephalomyelitis, or ADEM. So I think you can think of which one is likely in this patient based on the presence of encephalopathy. So this is another way of, another diagram to show you the same thing which I mentioned. So I will focus here. First demyelinating attack with encephalopathy is ADEM. And then when do we call these patients have multiple sclerosis? If they have second attack after 3 months, that is considered as MS. If they develop a second attack within 3 months, that's considered as part of the first episode. So we have to wait for this patient for about 3 to 6 months to see whether she developed another clinical attack or not. So here the question is our case CIS, clinically isolated syndrome, or ADEM? So I reviewed some literatures of cases which were reported as ADEM, and how is encephalopathy defined in those patients? So in the vast majority of patients, encephalopathy in ADEM was described as irritability and sleepiness in more than 50% of cases. In other cases, in the remaining 50% of cases, it is a clear-cut encephalopathy with coma, obtundation, or somnolence. So in this patient, the sleepiness can be considered as encephalopathy, which makes us, which strengthens our suspicion that this is more likely ADEM, acute demyelinating encephalomyelitis. So a little bit more about this condition. As the term describes acute, it is an acute disorder with encephalomyelitis, encephalopathy and myelopathy together. And we need a patient who have encephalopathy to suspect this diagnosis. So the lesions are usually multifocal. They usually affect the deep white matter and also the deep gray matter areas, including the thalamus and the hypothalamus. In more than 80% of cases, this is a monophasic disorder. It doesn't recur and usually affects children. It's not common in adults. It is much more common in pediatrics. It is usually preceded by some form of infection or vaccination. The infection can be weeks ahead of the clinical symptom, or just few days before the infection. The average latency period is about 7 to 14 days. So the neurological symptoms can be diverse because depending on which area of the central nervous system is involved. The patients can have paresis, they can be ataxic, their speech can be affected. They can present with seizures or with excessive daytime sleepiness, like in this case. So this is a diagnostic criteria which is established in 2012. The criteria include it must be a first polyfocal CNS abnormality. It is usually monophasic. Encephalopathy is a criteria for the diagnosis, and non-clinical or MRI findings in the first after 3 months. In the first 3 months, changes can happen, but that is considered as a part of the initial episode. And we need to have a typical brain MRI findings, which I have already mentioned. That means demyelinating lesions in the subcortical region, and some gray matter areas like the thalamus can also be involved. So there are no specific laboratory data that can support our diagnosis, like antibody tests. Mostly it is a clinical radiologic diagnosis. If we have that clinical data with supportive MRI findings, then we can diagnose them with ADEM. Regarding their CSF findings, in more than 50%, 60% of cases, CSF studies are normal. We may see moderate degree of lymphocytosis. Protein can be mildly elevated. And in 10% of cases, they may have oligoclonal bands. So oligoclonal bands are much more common in patients in multiple sclerosis, but the fact that a patient may have oligoclonal bands does not rule out ADEM if the patient does not fulfill the criteria for MS. And as I mentioned earlier, the prodromal reason for ADEM is infection, viral infection, but tests for viral infections are positive only in about 15 to 20% of cases. So the fact that the patient is negative for viral infections does not exclude this diagnosis as well. So what is the prognosis for these patients? Usually it is a monophasic disorder. They will the outcome is favorable. It will not recur. The patients they will do fine. They will recover within 6 months up to a year. But some patients may continue to have residual symptoms, including cognitive deficits and behavioral issues. So the question is, when are we going to suspect the patient? Because most parents are going to be worried that, is my child going to have MS? Or is this situation going to evolve into MS? It's very hard to tell from at the initial presentation. It's very difficult to tell. These are the two factors that has to be considered. If the clinical symptom lingers more than after 3 months of the onset, then that is a bad sign, because there's a possibility that the patient may continue to evolve into multiple sclerosis. If the patient improves, then that's a monophasic disorder. And it's not only clinical lingering, and if MRI shows a new lesion after 3 months, and that's also a problem. So those are the two situations. So another question which can arise is, let's say the patient develops new symptoms or new radiologic manifestations after 3 months, but still that clinical symptom or radiologic manifestation after 3 months do not meet the criteria for MS. Then what are we going to call that one? That one is called multiphasic ADEM. So it can recur after 3 months, but if the patient doesn't still meet the criteria for MS, which I'm going to mention in a little while, then we call that patient has multiphasic ADEM. So this is not that common, but it is possible. But we have to open our eyes if a patient develops new symptoms after like 3 months for a possibility of MS or NMO. I mentioned already about clinically isolated syndrome. It is a patient with demyelinating disorder with no encephalopathy, but first-time disorder. That's clinically isolated syndrome. These are most patients with clinically isolated syndrome usually tend to evolve into MS. Examples of clinically isolated syndrome include conditions like optic neuritis. If an adolescent patient has optic neuritis which is not explained, and those patients have a high risk to evolve into multiple sclerosis. So I tried to look into what predictors are determinant for evolution of CIS into MS, clinically defined MS, presence of oligoclonal bands, and new lesions on MRI, or involvement of the spinal cord. These are some of the common ones, but there are different literatures say different things. So a little bit about multiple sclerosis itself. So multiple sclerosis is much more common in adults as compared to pediatrics, but many patients will start to manifest multiple sclerosis during adolescence. So the age of onset can be, in pediatric onset MS anytime before the age of 18, but 14 to 16 is when you have to be suspicious. Anything after the age of 12 can be you have to closely follow up those patients. Before adolescence, before the age of 10, it is unlikely that that's a manifestation of MS. It's more of a monophasic disorder. Pediatric onset MS is also called early onset or juvenile MS. So before puberty, the male to female ratio of pediatric onset MS is the same. After puberty, females are more predominantly affected, like in other autoimmune conditions. These are the risk factors for MS, especially in children. Obese children are more at risk. Those with low vitamin D level are at risk. And there was an association which is noted in many literatures. Epstein-Barr virus infection predisposes patients for MS, and some genetic susceptibility with HLA allele, which is of DRB1501. So the clinical manifestations of pediatric onset MS before puberty are a little bit vague, and they could be multifocal. After adolescence is similar to adults, and it is usually a monofocal clinical manifestation presenting with focal sensory symptoms or focal motor symptoms, or just only optic neuritis. So just a focal manifestation. The reason for that is usually MS causes demyelination of a specific area, not a diffuse like ADEM in many areas. So the manifestation is usually monofocal. In more than 90% of cases, MS, even in adults, it has a relapsing and remitting course. But as compared to adults, in pediatric, almost all patients have a relapsing and remitting course. So the criteria for diagnosing multiple sclerosis, like in adults, is like the McDonald Criteria. I think most of you have heard of that. So the same criteria is adopted for pediatrics. So the criteria for these conditions are 2 or more clinically isolated syndromes separated by 1 month. If a patient has, for example, optic neuritis at one time, and after 4 months, a patient presents with transverse myelitis, and MRI shows involvement of these areas, then that fulfills the criteria. That is, there is a dissemination in time and dissemination in space involving different areas. Or they can present with first-time neurological clinical symptoms, but the MRI shows dissemination in time and dissemination in space. How do we know that there is a dissemination in time and dissemination in space after a first clinical manifestation just only by MRI? If we see lesions involving two different areas, that is telling us dissemination in space. If there are old lesions and there are new lesions which are enhancing, that means there is dissemination in time. So from the beginning, with first presentation, this is one of the ways we can diagnose MS. Like in the beginning, I said that if a patient presents for the first time, we can consider clinically isolated syndrome or ADEM. But this is one of the exceptions because it fits into the McDonald's criteria. It fulfills dissemination in time and space. The third criteria is one ADEM attack or one clinically isolated syndrome, and the patient presents with another neurological manifestation after 3 months. And the fourth one is a clinically isolated syndrome with dissemination in time and space on the MRI. So this is just a definition of dissemination in space, which I already said. But what are the most common areas which are usually affected in patients with multiple sclerosis? It can involve, there are 4 typical areas which are involved in MS. This include the periventricular region, the juxtacortical area, infratentorial region, and the spinal cord. Dissemination in time, we mentioned that it could be based on MRI, if there are non-enhancing and enhancing lesions, or if there is a 2 clinical attack, which is at least 1 month apart. So based on MRI, there are criteria which more favor MS as compared to ADEM or vice versa. So MS is more likely if the lesion is just focal. If it is diffuse or multifocal, it favors ADEM because in MS it is usually a chronic, remitting, and relapsing, affecting one area at a time at different times. You don't find multiple lesions at one time involving the subcortical region and infratentorial regions. Presence of black holes favors MS. Black holes are like dark hypointensity that you see on the T1 sequence. That means it is telling you that this is not an acute problem. It is a chronic problem which has caused damage to the brain, leaving that black hole. So if somebody has an old lesion which shows as a black hole and presents with a new clinical symptom, you know that the patient had a problem in the past which manifested radiologically, now presenting clinically. So black holes favor MS than ADEM. Presence of 2 or more periventricular lesions favor MS, but this can happen also in ADEM. But again, multiple periventricular lesions are more in favor to MS as compared to ADEM. Just moving forward to a different topic, because they are related, NMO spectrum disorder. Then, because MS, as I said, is much more common in adults, but NMO spectrum disorder is much common in pediatrics. But NMO overall is rare. When it happens mostly in pediatric patients. Previously, years and years ago, NMO was considered to be a variant of multiple sclerosis. Some people even considered it as a one-time monophasic disorder like ADEM. And it has evolved a lot over the years. It was first described by Dr. Ian Devick in 1895 when he came across a 45-year-old patient with leg weakness and urinary retention. And she developed neurological symptoms, including optic neuritis. So he did some pathology on the optic nerves and a spinal cord specimen, and he detected like necrotic chains, but he didn't know what causes this and why these areas are affected, just particularly the optic nerve and the spinal cord. And it has taken almost a century before people came across the potential cause and to understand a little bit more about this condition. And there were several misconceptions between the time when Dr. Devick described this and until more awareness came in. Actually, a significant progress has developed only over the last 20 or 25 years. It is in 2004 that people have discovered specific NMO-related antibody. And in 2004, they didn't know what that antibody was, but they detected the antibody. The target antigen was not discovered until like 2006, 2007. And the target antigen for that antibody was like found to be aquaporin 4. This is a water channel receptor. And in 2007, they confirmed that that is the cause, like, the antibody which is responsible for this disorder. And in 2015, they have came up with a more recently revised criteria for the diagnosis. So, like as I said, the first time it was discovered, this disorder was known by the name Devick syndrome because of Dr. Devick. And the definition was when a patient has optic neuritis and acute myelitis, that's when you diagnose that disorder. But now there are more expanded criteria. So these are the 6 core clinical characteristics of NMO: optic neuritis, acute myelitis, area post-traumatic syndrome. The area post-trauma is a region of the brainstem in the dorsal aspect of the medulla, and it manifests with like it controls autonomic symptoms like heart rate, blood pressure, and vomiting and swallowing. So patients present with vomiting, uncontrollable hiccups, and things like that. So if a patient has, you have to specifically ask for, uncontrollable hiccups and vomiting to check for this syndrome. Acute brainstem syndrome, midbrain involvement, and symptomatic narcolepsy is a criteria for NMO. Like our patient had basically clinically, she presented with narcolepsy, even if she didn't have sleep study tests, which can confirm this diagnosis. And the other one is symptomatic cerebral syndrome, like any CNS manifestation, seizure, or things like that. So to diagnose NMO spectrum disorder, it is different depending on their antibody status. If aquaporin 4 is positive, what we need is just one core clinical characteristic, either optic neuritis, acute myelitis, area post-traumatic syndrome, the things which I have mentioned. So if somebody is aquaporin positive, just you need one thing, even just hiccup or narcolepsy, NMO. And if the patients are aquaporin negative, seronegative NMOs, those are the ones that need more criteria. If they are negative for the antibody, what we need is at least two criteria. But one of them must be optic neuritis or long segment transverse myelitis. The term long segment myelitis is important here. What that means is at least 3 or more segments of the spinal cord should be involved. This is important clinically because in MS and other demyelinating conditions, the segment which is involved in is only 2 or less. If it is 3 or more, it is more in favor of NMO. So if a patient is seronegative, we need 2 criteria, among which one must be optic neuritis or long segment myelitis. And actually you have to exclude other criteria. So that is exclude other criteria. So about 40% of patients are seronegative for NMO. These patients can present with optic neuritis, or they can present with ADEM-like symptoms or transverse myelitis, or a combination of any of these things. So it is a clinical manifestation can be so diverse. It is easier when they are aquaporin positive. If they are negative, we need 2 criteria, with one being optic neuritis or long segment myelitis. So I think I will stop here and to open discussion, to answer some questions, and if you have any comments. But the takeaway point from this presentation is, one, probably most pediatricians do this as an anticipatory guidance. It is very important to take detailed sleep history. Even for other things migraine, we see a lot of patients with migraineurs here in our office. But when you dig into their sleep history, they go to bed around 3 or 4, and they have to wake up for school at 6. So that is very important takeaway point. We have to use the screening points to be quick and also not to miss details of sleep information about the patients. And we have to think of that excessive daytime sleepiness in adolescents can be secondary to serious neurological disorder. It's not only because teenagers are just people who are staying up late on YouTube and social medias. So it's very important to get a detailed history and consider further workup as needed. And this is other takeaway point is at least having an overview of MRI findings in different demyelinating conditions, like in MS, what favors MS more than ADEM, and what favors more of neuromyelitis optica. Like I said a while ago, that when there is transverse myelitis, in NMO, it involves more than 3 segments. The same thing applies for optic nerve involvement. If there is optic neuritis, and the segment which is affected in NMO is more than 50%, and in MS, the optic neuritis usually involves less than 10, about 15-20% of the segment of the optic nerve. So in some situations, you can do a specific imaging for the optic nerve and measure how the length of the optic nerve involved. And more than 50% of the segment is involved, it favors NMO. And also in terms of MS, it usually affects a monofocal region, usually affects the periventricular area as well. And black holes are more in favor for MS. For ADEM, they usually are subcortical, and they involve multiple regions. And ADEM is monofocal, and usually you require encephalopathy as a criteria. So for MS diagnosis, we need McDonald's criteria. For NMO, if they are seropositive, we need one core clinical manifestation among the 6. If they are seronegative, we need 2, but one of which must be optic neuritis or long segment transverse myelitis. I have 2 questions here. I will check the chat box to see if there are questions. Before I go to your questions, I have these 2 questions. So the first one is MRI brain of a 12-year-old female presenting with first-time subacute course of confusion, showed multiple subcortical demyelinating lesions. The most likely diagnosis in this patient is MS, ADEM, acute demyelinating encephalomyelitis, NMO, neuromyelitis optica, CIS, clinically isolated syndrome. You can drop your answers in the chat box. Yeah, I see a lot of you dropping your answers in the chat box, and almost all of you have gotten the right answer. The answer is B, ADEM, 12-year-old. This is a first-time demyelinating lesion. The confusion is telling you that the patient is encephalopathic, and the MRI is telling you that it's a multifocal lesion, and that is acute demyelinating encephalomyelitis. Excellent. Question number 2. In a patient with optic neuritis, if MRI spine shows evidence of long segment myelitis, the diagnosis is in favor of multiple sclerosis or neuromyelitis optica. Yep, again, all of you answered this question as well. It is, the answer is NMOB. The important point here is that, optic neuritis can be due to any monophasic disorder. It can be a manifestation of MS. It can be a manifestation of NMO. Important point here is the MRI of the spine showing long segment. That is the keyword, the long segment. That means if more than 3 segments are involved, that will narrow down the diagnosis to NMO. Excellent. And I will check if these are my references. I hope Jenny will share the slides to you. You can take a look into the references for more details. If there are any questions in the next few minutes, we can discuss. I see, I'm going to read, that is from, okay. I see a question here from Hannah. Is low vitamin D cause or correlative? Is there thought to be any protective effect of maintaining normal vitamin D levels? So that's a good question. So there is an association between, it is not a direct causative relation. There is nothing which is known to be a cause for MS. Because MS is considered, like as I said, it is multifactorial. We put obesity, low vitamin D, and some HLA genetic predisposition as a risk factor, but nothing is considered to be a direct causative agent. So it's not causative. It is more of a correlation. Those who have low vitamin D tend to be more at risk for MS. The hypothesis behind this is that vitamin D is very important to modulate and to enhance the immune system. And in those who are low in vitamin D, their inflammatory response, their immune defense system is either disorganized or poor, predisposing them for dysregulated immune response and causing damage like this. So, and yes, because of this questionable relationship, people recommend that patients' vitamin D level be maintained in a normal range. So most patients who are diagnosed with MS will be put on vitamin D to make sure that their level is optimal. We had seen a case, 2-year-old with fever and sleepiness, initially diagnosed as meningitis. Initial MRI showed only gray matter lesion. So I think later found to have white matter lesions after a week and treated as ADEM. So this one, okay, this is a good question because you specifically mentioned that this patient presented with fever and MRI showing lesions. So when you diagnose ADEM or the other demyelinating conditions which I discussed, fever should not be there. So encephalopathy, not due to fever. I probably have mentioned that on one of the slides, but I didn't say it. If the cause for encephalopathy or the cause for the CNS manifestation and is in relation to the fever, that automatically rules out those differentials because that is more in line with direct infectious cause. ADEM is a post-infectious after vaccination or an infection which has resolved. If there is active fever, it is more of a meningoencephalitis. So this patient doesn't meet a criteria for ADEM or demyelinating lesions, even if there are lesions on gray matter and white matter, just because of the presence of fever at the time of diagnosis. Yeah, thank you everyone for listening.